Hello, welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. I'm Meg Fleming from Emory University, and this session is the first of two add-on modules focusing specifically on nuclear radiology. This one focuses on coding. This module is specifically targeted to address components of Level 3 of Nuclear Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. The next module will focus on components of both Level 3 and Level 4. All of the other level requirements for nuclear radiology are addressed in various modules in levels 1 through 5 for diagnostic radiology. I encourage you to look closely at the RSNA's website to learn more about how modules map to different levels in different programs. You have already heard about coding in general and how Medicare pays for services. But in these nuclear radiology modules, we'll talk about those items specifically as they pertain to nuclear radiology. The learning objectives for this module are as follows. Discuss CPT and ICD codes as they relate to nuclear radiology, and to review common nuclear radiology coding scenarios. Additional resources for this material are the American College of Radiology Nuclear Medicine Coding User's Guide and the American Medical Association's CPT book. Let's review from other modules in the Replete curriculum. This is the payment chain, and each link in the chain must be intact, all the way from pre-authorization to valuation and payment, in order for us to be reimbursed for our services. Let's focus on the middle link in the chain for this module, coding for nuclear radiology. Remember that CPT stands for Current Procedural Terminology and tells us what service was rendered. Here are a few common examples of CPT codes in nuclear radiology. Again, they describe what study is being performed. An ICD code is the International Classification of Disease Code and denotes why a service was rendered, specifically what sign, symptom, or diagnosis prompted the exam. We currently use ICD-10, which was adopted in October 2015. These ICD-10 codes may be used as indications for some common examinations in nuclear radiology. Again, note that they state why a study was performed. There must be concordance between ICD and CPT codes for reimbursement. As you can see, prostate cancer is an indication for a bone scan, shortness of breath for a lung scan, and right upper quadrant abdominal pain for a hepatobiliary HIDA scan.
Perfect.
So, if we changed our indications for our studies, we cannot bill a lung scan for prostate cancer, nor can we bill a hepatobiliary scan for shortness of breath. And right upper quadrant pain is not an indication for a whole body bone scan. Let's review a few examples. To start, here is a bone scan. In this case, it's a whole body bone scan. But you can see from the snapshot from the coding book on the right that there are a few options depending on how much of the body is scanned. To code for the whole body scan, the head to at least the knees must be imaged. Furthermore, you cannot code for more than one of these exams at a time, since all exams here would be encompassed in the whole body scan. Here we have two bone scans. In the image on the left, we have a 3-phase bone scan. In the image on the right, we have a whole body bone scan. What if these were performed on the same patient on the same day? Can you bill for both codes? No, you cannot report both codes, since the whole body scan is the same as the delayed static bone images from the 3-phase study and is therefore already included. It would be appropriate to report 78315 only, given that the whole body scan is considered the 3rd phase of the 3-phase study. Let's look at another scenario. Let's say the patient shows up, receives the radiopharmaceutical dose, and then for some reason does not return, or the patient becomes ill or claustrophobic, and the exam is not completed. In this case, when you administer the radiopharmaceutical, you have begun the test. So, code the lowest level CPT code in the intended body area. You may bill for the procedure completed, such as a limited examination. In this case, code 78300, bone and/or joint imaging, limited area, and a modifier should be assigned, such as modifier 52 for reduced service or modifier 53 for discontinued service. You may remember from other lectures in the Replete series that CMS, the Centers for Medicare and Medicaid Services, has certain metrics that affect your reimbursement rates from CMS in the Quality Payment Program, QPP. Well, bone scans play a role in your quality score. It's hard to read on this image, but there is one of them. Let's take a closer look. Bone scans are included in the QPP, the Quality Payment Program, in 2 ways. The first is in relation to using comparison studies. So, simply documenting in your report that you compared to relevant prior imaging will satisfy that measure. The second is limiting use of bone scans, particularly in patients who have low-risk prostate cancer. Now, back to our patient who had a whole body bone scan. Which CPT code or codes should be reported? First, the CPT code 78306 is reported since whole body images were obtained. Second, the code for the radiopharmaceutical is also reported, in this case, A9503 technetium MDP. It is important to remember to code for both the scan performed as well as the radiopharmaceutical administered. Similar to a bone scan, PET-CT has different CPT codes based on how much of the body was scanned. A limited area, such as the head and neck, or from the skull base to the mid-thigh, or the whole body, which describes a study extending from the vertex of the skull to the feet. It is important to state the extent scanned in your report so that the appropriate code is assigned to your study. The PET-CT CPT codes 78814 to 78816 are used to report a PET and CT concurrently obtained at the same session on a PET-CT integrated system where the CT portion of the study is co-registered with the PET images. PET-only imaging without CT is reported with a different code set. What can and cannot be billed in addition to the PET-CT codes? CT studies should not be reported separately unless medically necessary and ordered by the referring physician. In order to bill for an additional CT, clinical necessity, noted by the referring physician order, will determine if a diagnostic CT is indicated concurrent with a PET-CT examination. 3D rendering images should not be reported in addition to PET-CT codes. The 3D rendering is a basic component of all tomographic nuclear medicine studies. So reconstruction imaging such as sagittal, coronal, 3D, and maximum intensity projection MIP imaging has been valued into these codes already. Which CPT code or codes should be reported for our PET-CT? First, the CPT code 78815 is reported since it's more than a limited area but does not include the lower legs or feet. Second, the code for the radiopharmaceutical use is also reported, in this case, A9552 F18 FDG. Again, remember to code for both the scan performed as well as the radiopharmaceutical administered. Similar to the bone scan and PET-CT examples we have just seen, lung ventilation and perfusion, or VQ scans, have specific codes based on exactly what test or tests were performed. So a VQ scan for both ventilation and perfusion, in order to diagnose pulmonary embolism, code 78582 would be reported. However, a quantitative perfusion scan, such as in patients undergoing preoperative assessment for pneumonectomy or lung transplantation, code 78597 would be reported. Alternatively, if the patient undergoes a quantitative ventilation and perfusion scan for quantification of both pulmonary ventilation and quantification of pulmonary perfusion, for patients with lung cancer and severe obstructive pulmonary disease, or evaluation before and after lung transplantation, code 78598 would be reported. As with other nuclear radiology studies we've reviewed, CPT codes for the radiopharmaceuticals also need to be reported. Next, we'll take a look at hepatobiliary imaging, also known as a HIDA scan. In the case of determining if a patient has acute cholecystitis, code 78226 would be reported. However, in the case of chronic cholecystitis or concern for biliary dyskinesia, where a gallbladder ejection fraction is reported, then code 78227 would be reported. The CPT code for the radiopharmaceutical also needs to be reported, such as Cholotec, noted here. For our last example, let's take a look at gallium. The codes on the right of the slide are used for a variety of types of tumor imaging. For example, gallium citrate, indium-111 pentatriotide, prostacin, and technetium-99 use these codes. If more specific codes are available, then those would be used. For instance, thyroid imaging has its own set of codes, and therefore this code set would not be used. In the case of tumor imaging in gallium, these codes would be used. With gallium, often delayed imaging, such as 72-hour images, are obtained. Therefore, the study typically takes more than 1 day. So, of the options noted, then whole body requiring 2 or more days imaging would be selected. If both 72-hour whole body images after gallium administration and additional 96-hour delayed images are obtained, then 78804 is still used and only coded once, since the description encompasses 2 or more days of imaging. What if the whole body scan plus SPECT images are obtained? Then code 78803 can be used in conjunction with 78804. However, based on the Medicare multiple procedure policy, these codes are subject to the multiple procedure discount. That is, contractors pay 100% of the highest paying procedure on the claim, plus 50% of the applicable payment rate for the other covered procedure. If SPECT is performed in multiple areas, such as chest, abdomen, pelvis, and/or performed over multiple days, it is only coded once. Additionally, the code for the radiopharmaceutical, in this case gallium-67, would also be coded. In summary, CPT codes should reflect the extent of the body scanned. Careful attention to the specific codes in the code sets is necessary to select the appropriate code for the imaging study performed. And always report the radiopharmaceutical CPT code. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the REPLETE initiative and additional resources are available on the RSNA's website. I'm Meg Fleming from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in REPLETE.